السلام عليكم ورحمة الله وبركاته. النهارده هنتكلم عن Intermedullary Headless Screw Fixation for Metacarpal and Phalangeal fractures and also tips and tricks. Firstly, I want to thank Professor Amr Said, Professor Walid Riyad, Professor Yasser Farouk, and Dr. Ahmed Adil for their support and efforts. Metacarpal and phalangeal fractures represent 41% of all fractures observed in the hand and forearm. There are various approaches have been documented for addressing displaced and unstable fractures. The treatment options either by non-operative management or operative management. The operative management either such as blatant screws, lag screws, K-wires, or even X-fix in fractures. This is an example of fracture of the fifth metacarpal fixed by K-wire by bouquet technique and end with stiffness of the MB joint. So the K-wire is a minimally invasive technique, but don't allow early mobilization, stiffness, pin tract infection, fixation loss, and need hardware removal. Another example of fracture of the fifth metacarpal fixed by blatant screws, it's also end with stiffness of the MB joint. So the main complication in all reports is stiffness, soft tissue dissection, devascularization of bone, impingement with gliding structures, scarring and adhesions. All these complications open a new door for the new era and new technique of intramedullary headless screw. It was first described by Bolton in 2010 as a case report with good results. Then Del Binal published a paper in 2015, described the minimally invasive technique of these fractures with excellent results. This is a paper published by Dr. Walid Riyad, Dr. Ahmed Adil, Dr. Yasser Farouk, Dr. Amr Said, and me. It is a case report published in World Journal of Orthopedics this month. It is the largest case series in Africa and Middle East. It's conducted on 67 fractures, including metacarpal and phalangeal fractures, in 53 patients fixed by intramedullary headless screw, operated from January 24 to March 25 in the trauma unit and hand reconstructive microsurgery unit, Assiut University Hospital. The type of screws that were used in our series: Herbert screw, 2.7 millimeters, Herbert screw, 3.5 millimeters, Accotrack screw, 4 millimeters fully threaded. This is an animation video demonstrates how to perform the surgical technique in a simple way. First, flexion of the MB joint and reduction of the fracture, insertion of the guide wire in line with the medullary canal, and must be in the dorsal 1/3 of the articular surface. Then reaming of the medulla and insertion of the screw, and the screw have to be beneath the articular surface about 2 millimeters. Then closure. In a real patient, this is AP and lateral view, demonstrates the K-wire in line with the medullary canal and in the dorsal 1/3 of the articular surface in lateral view. After fracture reduction, the K-wire is advanced to the base of the metacarpal. Then the appropriately sized screw is overlaid the bone, and fluoroscopy confirms the correct width and length. Then the metacarpal is drilled, and it's important to ensure the narrowest part of the canal is reamed sufficiently to accommodate the screw threads. Then the screw is then hand-driven with fingers flexed to prevent rotation. Confirm screw placement using fluoroscopy and recheck for any malrotation. Then the guide wire is removed and skin is closed by single suture. In the proximal phalanx fracture, the guide wire is inserted percutaneously into the dorsal 1/3 of the phalangeal head. Then the guide wire is advanced after reduction of the fracture till the subchondral bone. Then the proximal phalanx is pushed dorsally at 70 degrees of flexion of the MB joint to provide a dorsal subluxation. Then the guide wire is advanced till exiting the skin without violating the metacarpal head. Then the bone is drilled antegrade from proximal to distal. Then the screw is then hand-driven with the fingers held together to prevent rotation. Confirmation of the screw placement under fluoroscopy and recheck for any malrotation. Finally, the guide wire is removed and skin is closed by single suture. The post-operative care, no splint needed, early active range of motion from day one. Stitches were removed 2 weeks post-operatively. The results of our series, including Group A and Group B, Group A metacarpal fracture and Group B phalangeal fractures. It was most commonly comminuted fracture in the metacarpal group and transverse pattern in phalangeal group. Also, we achieved about 94% closed reduction in metacarpal group and 100% in phalangeal group. And also the operative time ranges from 10 to 30 minutes, and 30 minutes reached when we perform an open reduction, but in closed reduction, it's much shorter time. Also, excellent result according to total active range of motion, grip strength, dash score, and VAS score. The complications, there are no cases of infection or non-union, but only one case of shortening with metal protrusion and one case without metal protrusion in each group. Illustrative cases. Case 1, a male patient 21 years old, fracture of the fourth metacarpal, closed reduction and fixation by Herbert screw 3.5. This is an intraoperative image and range of motion. One year follow-up, it's fully united, full range of motion, and the patient is satisfied. Case 2, male patient 25 years old with multiple metacarpal fractures. We performed an open reduction and fixation of the third metacarpal, but closed reduction and fixation of the fourth and fifth metacarpal. 6 months follow-up, fully united, full range of motion, and the patient is satisfied. Case 3, male patient 27 years old with fracture of the proximal phalanx of index finger, closed reduction and fixation by Accutrack screw 4 millimeters. This is an intraoperative, it's full, it's nicely aligned and full range of motion. 8 months follow-up, it's fully united, full range of motion, and the patient is satisfied. This is the case of complication. Male patient 38 years old with fracture of the fourth and fifth metacarpal. The fourth metacarpal is a comminuted neck fracture. We achieved the closed reduction and fixation by Herbert screw 2.7 millimeters because the larger diameter screws are out of stock at that time. This is an intraoperative image. It's well aligned and fixation. 3 months follow-up. It's uniting, but we noticed a protrusion of the screw head in the MB joint in the fifth metacarpal. Despite of this complication, the patient have full range of motion and he is satisfied and refused revision surgery. Take-home message, intramedullary headless screw fixation proved to be a safe and effective surgical technique. Intramedullary screws seem to achieve a good balance between keeping mobility and preserving alignment and soft tissue. In a comminuted metacarpal or phalangeal fractures, should use fully threaded Accutrack 4 millimeter screw rather than smaller or partially threaded screws. The advantages, minimally invasive technique, preserve preosteal blood supply, biomechanical stable, reduced hardware prominence, faster return to activity daily living, low complication rates, good cosmetic outcomes, short operative time. And this advantage is technically demanding, risk of intra-articular damage, cost of implants, difficult hardware removal, and it is not ideal for pediatric patients. Thank you.